FNUU Quandaries session, which will involve talks on three interesting topics. The first one will be female retention, which will be delivered by Magda Khawaja from Stockport. Then we're going to talk about overactive bladder, and Altaf Mangera is going to give us an insight on that topic. And finally, we'll finish with Siobhan Wolsey, who'll talk about urinary incontinence in the elderly. So without further ado, we'll start with Magda and female retention.
Thank you very much. So to be in a quandary is to be in a state of perplexity or uncertainty. And that's often the situation we find ourselves when we're presented with a female in retention. Why is that? Well, it's uncommon. An instance is quoted about 3 per 100,000 per year. And overall, it's thought to represent about 7% of compared to male acute urinary retention. It's poorly understood still. And it's challenging to manage, not only the condition, but the patients themselves, I'm sure you'll agree. So, what is it? The etiology is often thought to be bladder outflow obstruction, detrusor failure, or a combination of both. Whereas in men there is a clear consensus of bladder outflow obstruction, it's not so clear in women. There are various different nomograms and descriptions in the literature, from video urodynamics to interpretations of Qmax, maximum flow, and detrusor pressure at maximum flow, but there's no clear consensus. We've heard today in the poster session just before about a new nomogram, the Solomon-Greenwell nomogram, which promises greater concordance. The many causes, the etiology, are diverse. This is actually quite a comprehensive list I've found here, but as you can see, there are many possibilities to think about when presented with patients. However, again, in the literature, there's very little about the actual instance of these etiologies. This was a study from Glasgow, over 11 years, a collection of 300 cases of female urinary retention that had presented. And it's probably the largest series I could find in the literature. Interestingly, you'll see at the top, there was no positive diagnosis in about 28% of patients. Fowler's syndrome, which attracts lots of attention, was actually only diagnosed in 0.3% of these patients. So when we've excluded anatomical, mechanical, infective, myogenic causes, we should think about functional causes, which again, there's very little understood about and written in the literature. I'll discuss Fowler syndrome in a bit more detail in a moment, but that's basically a failure of relaxation of the external urethral sphincter during voiding. Other diagnoses are dysfunctional voiding, or what we know as Hinman syndrome, neurogenic bladder dysfunction. And that's thought to be as a failure of pelvic floor relaxation and possibly external urethral sphincter relaxation also. And it's thought to be a learned behaviour, and it's more commonly seen in children. There's very little written about what happens to those children when they become adults. Primary bladder neck obstruction, akin to what is seen in men, whether that's a smooth muscle hypertrophy or a neurogenic phenomenon, is a possibility. Idiopathic detrusor underactivity, which is a failure of detrusor contraction. The kind of situation you see is more commonly in older patients. It's classically the older lady who presents having had a hip replacement and then is unable to void post-operatively. And even given a trialed out catheter can continue to fail to void. And last but not least, chronic intestinal pseudo-obstruction, which before researching this talk, I'd never heard about. Just to emphasise the difficulty in diagnosis, this was a retrospective review of a group of women referred to Queen Square, the National Hospital, with unexplained retention. 247 ladies were referred. 57% of them were diagnosed with Fowler syndrome, but 32% had no diagnosis. So to discuss Fowler syndrome in a bit more detail, what we understand by it. It's urinary retention in the premenopausal woman. Classically, they present immediately post-operatively after an unrelated procedure sometimes. They have little bladder sensation and therefore present with large residuals. And as I said, it's thought to be as a failure of relaxation of the external urethral sphincter. When this was first described, there was some note of the patients were obese, hirsute, and there was some association made with polycystic ovary syndrome. But that's only in about 64% from the original description. They classically have an abnormality at electromyography, which I'll discuss in a moment, and also are noted to have increased maximal urethral closure pressures and increased sphincter volumes on transvaginal ultrasound scanning. On urodynamics, they classically have poor sensation of their bladder filling with a large bladder capacity and are unable to mount detrusor contraction. And this is thought to be because of an increased urethral afferent activity, which has an effect on the spinal cord, inhibiting the bladder afferents that normally feed back that information to the higher surgical centres that control bladder sensation, the periaqueductal grey particularly. And effectively, it causes an exaggerated guarding reflex. This is a nice depiction from diagrammatically showing that the increased urethral afferent activity blocking the effect of the bladder afferents, feeding back via the sacral spinal cord to the higher brain centres, and offers a solution in blocking the urethral afferents as a possible therapy for these patients. Again, more of that later. The abnormal EMG activity attracts a lot of attention. EMG is a particular, as a neurophysiological study of striated skeletal muscle, and it's particularly useful looking for re-innervation, denervation, and myopathies, and has been used in the diagnosis of multiple system atrophy. When applied to these patients, it was noted a particular type of abnormality, these complex repetitive discharges and decelerating bursts, that on the audio output of the EMG machine were akin to helicopters and whale song. This abnormal activity is thought to represent ephaptic transmission, which is abnormal muscle-to-muscle transmission of electrical activity, which is thought to be due to an ion channel dysfunction or some hormone-related mediated channelopathy. It's thought that these complex repetitive discharges cause autonomous, circuitous excitation of the sphincter muscle, which then cannot relax during voiding. However, we found, this is the work that I presented at BAUS in, I have to say, 16 years ago now. I know I don't look that old. But basically, we looked at some normal women volunteers and found these same abnormalities, these same EMG abnormalities in normal volunteers. They were subsequently followed up 10 years later to see if any of them had developed urinary symptoms. None had. And another group in America actually found similar incidents. I think we found about 35% of normal women had these changes at EMG, and I think they found up to 53% of women, but these were women presenting for urodynamics because of urinary retention, so it weren't completely asymptomatic, but they were not symptomatic of retention. So other factors come into play. The British National Formulary states a risk of acute urinary retention because of opiate use, and it's thought that opiates inhibit the sacral parasympathetic efferents that then lead to some loss of detrusor function. This was a study looking at 61 women referred to Queen Square again over 12 months with retention. 56% of them had no cause for this retention, but quite a number of those women were on regular opiates. Several of them actually had restoration of normal voiding on withdrawal of those opiates. So inevitably, there's some other factors that come into play in these women. They also seem to have comorbid conditions, which is something that when you look after these women regularly, you get some suspicion of, although there's very little in the literature written about it. A lot of them have chronic pain syndromes, some functional neurological symptoms, particularly things like leg weakness, and a lot of them have some psychological symptoms. Historically, these women were labelled as hysterical, but there is very little in the literature about their psychological factors. And we know from work done that there's an association between physical and psychological abuse in children, in particularly with urinary symptoms. There are similarities and associations with these disorders such as non-epileptic attack disorder, which is described as a biopsychosocial disorder, whatever that means. But these are genuine conditions and are thought to represent interaction between physical and psychological. So, what do we do with these patients when we see them? There is no clear pathway of how these women should be managed. When they do present, you hope they have a simple cause, and the obvious thing is, post-stress incontinence surgery, for example. But many of them, on detailed history taking, it may not be evident. So what kind of investigations would we expect to do? Well, obviously, a pelvic and neurological examination, ultrasound scanning of the pelvis, cystoscopy. Some people advocate MRI of the spine, although actually the use of that is questioned because it rarely shows anything useful. And then video urodynamic studies, which I think in women with voiding dysfunction is underutilised. It can be quite helpful. It can help you determine the level of obstruction if the patient is able to void. And this just shows obstruction at the bladder neck, obstruction at the level of the external sphincter, and obstruction at the level of the pelvic floor. Should we do electromyography? Well, very few centres actually can offer it. Characteristic findings in Fowler's syndrome, as we've suggested. Surface electrode EMG can be quite useful in the investigation of dysfunctional voiding, because if you remember, the tonically active sphincter will become silent during voiding, whereas in dysfunctional voiders, it continues. Sphincter ultrasound scanning, is that useful? It's extremely variable technique, as is urethral pressure profilometry. The most important thing with these patients is that after failed trial without catheter, if they still can't void, that early teaching of intermittent self-catheterization should be instigated. Patients with Fowler's syndrome particularly find this difficult because of difficulty inserting, and particularly they describe a gripping sensation on removal of the catheter which they find painful. But patients should be encouraged to persevere with it, because we know many end up having suprapubic catheters, which just causes more bladder pain and increased opiate usage. And some advocate the use of continent diversion for these patients. With respect to primary bladder neck obstruction, there is some success using alpha blockers, and also failing that, transurethral bladder neck incision, with reported limited incidence of stress urinary incontinence after. For the dysfunctional voiders, biofeedback is the main form of management. Again, there's a little bit in the literature regarding success objectively and subjectively with increases in Qmax and reduction of residual volume. With respect to Fowler's syndrome, no pharmacotherapy helps. Alpha blockers don't help, and urethral dilatation doesn't help. There was a study using sildenafil, the theory being that increasing nitric oxide might help relax the sphincter, but again, no benefit. In the early days, intraurethral Botox injection was tried, again, with very little benefit. There's been a bit of a revival of intraurethral Botox. It's primarily been evaluated in neurogenic detrusor sphincter dyssynergia and in spinal cord injury. But there are very small numbers in the literature, which makes it difficult to draw clear conclusions. This is the largest group I could find. It was a Taiwanese paper, and it looked at 16 women undergoing intraurethral Botox using 50 units, and it promised a modicum of success. However, the group was really heterogeneous, and it was difficult to know exactly what they were treating. So sacral neuromodulation has really made a big difference to a lot of these women in that it can restore normal voiding in up to 76% of patients. Interestingly, those with a proven EMG abnormality do seem to fare better. It comes with a complication and revision rate, problems with box site pain, sciatica, and often has to be revised. And it's thought to work by modulating spinal and supraspinal reflexes via the efferent effects on peripheral afferents rather than a direct effect on the bladder or the spine, the sphincter efferents. And this has been supported by PET studies and functional MRI studies. It's a technique that's been modified several times. Previously, a percutaneous wire was used to do a test, and now a definitive tined lead is used for both the test period and for definitive placement. And this has led to a much higher rate of success. And there's a newer tined lead now also, which seems to have more promising results. And this is how it looks, in case you've never seen it. So going forward with females in retention, one thing that we've noticed is, just a lack of lack of studies generally. One of the things that we're particularly interested in is creating a registry of patients with that present with urinary retention. The renal division of the NIHR have a RADAR trial, which is a registry of rare diseases in the renal disorders. The benign neurology section of the NIHR is actually within the renal division, and so we're looking into hopefully creating a registry so we can recruit these patients into it, so to enable us to study them further. And this counts as NIHR accrual for the portfolio, so it's an attractive option. But basically, we're still left with a situation of it being a quandary. Hopefully with the Solomon Greenwell nomogram, maybe we'll get some better consensus. And I think this is the essential first step with female bladder outflow obstruction. The significance of EMG findings is still not really clear, but we must remember this is still a definitive test of skeletal striated muscle. And we know that patients with abnormality on EMG do seem to do better with sacral nerve stimulation. Do we still need to investigate with sphincter, with UPP and sphincter ultrasound? Well, again, there's because of the technical variability, I think this is a difficult question to answer. I think measuring UPP perhaps with the new airfield catheters may help with technical reproducibility. And what about things like MRI? Would that lead to consistency better with measuring sphincter volume? The elephant in the room has always been for these patients about looking into their psychology and their comorbidities. And I think it would be essential, if we're going to move forward for these people, to involve and collaborate with other specialties such as psychology. Thank you.
Thank you very much for your very comprehensive talk. It's you covered all the topics. I just have one question or comment. You did not mention the situation of post-delivery retention. And we don't know exactly what is the mechanism of these women suffering post-obstetric retention. And do you have any comment about it?
We see it not infrequently. We usually try and teach them self-catheterization, because in the majority of patients, it will settle over about 6 months or so. But then if it persists, then I would investigate them, as I mentioned, going down exactly the channel: cystoscopy, ultrasound, MRI, and video urodynamics.
Any comment from the audience?
Roving mic.
Come on, Tamsin.
Tamsin's got a hand up. Mic here at the front, please. Thanks.
I would say that is Scooter Solomon in here? No.
Turn the mic on, please.
Scooter would say that there is a standardised, well-recognised method for UPP measurement, the Brown-Wickham method, and I'm sure he'll tell you in detail if you want to be excited by the details. And we're just about to publish a paper on, so the name of ours has been published, but Neosera has written up our UPP and EMG experience, which quite nicely shows that if you have an irregular pattern to your UPP, a pulsatile pattern on it, then that's highly associated, strongly associated with having an abnormal EMG.
Which is what Claire Fowler's work showed originally.
So you can do one test and then hone down on those patients in whom you need to do an EMG.
I think as a urological community, though, we're still a little bit unsure of UPP.
But we're very clever people.
But we're very clever people and we can work it out. And I think these new air-filled catheters, as I understand it, are a little bit easier to use with respect to consistency of findings.
But they don't show an abnormal pulsatile trace.
Do they not? Okay.
It damps it out. And the other thing I wanted to say was the psychology of Fowler syndrome. I went to a talk, I listened to it, and they said there may be some sexual abuse. So I said to a woman with Fowler syndrome, did you have some sexual abuse? And she went, yes. And then we kind of looked at each other. And I went, right, well, can we now? I mean, what are you supposed to do?
Yeah,
How is talking to a psychologist going to make them be able
Well,
to do?
I just think it's, as I said, it's always been the elephant in the room. It's always been something that we have suspected. I know, speaking to Chris Betts, who has strong opinions about this sort of thing, that involving other specialties who have got more of an interest. We're surgeons, we're not trained to deal with that kind of thing, but we need to involve these other specialties in that assessment.
We've got Julian at the back.
Thank you very much. The issue of post-delivery and post-surgical retention is very important, and it's fine to discuss it in this environment. But where it needs to be discussed is with nurses and junior doctors. It is often unrecognized, and patients go on to develop overdistension injury from large volume retention. And the natural cascade of this, which we have seen many times in our unit, is normal bladder, retention, catheter, no bladder. In other words, with urinary diversion. And it comes from failure to recognize that the patients, once they've developed retention and they've been overdistended, never void normally again. They're sent home either with a catheter in or without a catheter with residual urinary significance, and they end up with suprapubics, and they always cause pain and small capacity bladders leading to urinary diversion. So the point you made at the beginning in one of your slides, which was asking them to persevere with intermittent self-catheterization, is fine and is what should happen, but that depends upon the nurses who are trained in this, telling them that's the only treatment available and nothing else. Because if they don't do it, they won't do it, and if they don't do it, they end up with diversion. So I think that group is very important, and most of the time in these patients, you can do as many tests as you like, it doesn't help you, because at the end point is intermittent cath. And the final thing I'd say about sacral neuromodulation is the question of whether it's all bullshit, because nobody knows anything about sacral neuromodulation, and your incidence of complications is massive, 50%, in a device is that going to last a patient's lifetime? And the answer is, of course it doesn't. It lasts 7 years, the batteries run out, and then what do you do? So I think you should seriously consider, what is sacral neuromodulation doing? Is it of any benefit, and is it just a temporary event in eventually doing something like a diversion?
So,
Susie.
a quick comment.
Julian's just announced his retirement from our unit.
He's just telling it the way it is.
Can I just ask a quick question about this? These patients create the most enormous amount of work, and you said something about persisting with them catheterizing, but they cannot catheterize because of the pain, or they say they cannot catheterize.
I know, I take Julian's point, and we really do encourage them to we really try and persevere. And sometimes they do wear you down. And I've certainly put suprapubics in young women, knowing that wasn't the right thing to do. But how else do you deal with it? Because otherwise they just keep bouncing back into hospital with urethral catheterization and causing consternation.
Yeah. But I mean, I'm delighted to hear we're going to get a registry going, because I really think this is the only way. But I do wonder whether they've got a genuine problem and we're missing a diagnosis.
Yeah.
Last
agree.
very short comment.
Okay, yes, very short comment. I'll just play devil's advocate a little bit
Yeah.
and say that you mentioned about querying whether MRI would be useful, whereas also querying about UPP and EMG of the sphincter. In a scenario where one positive MRI may not come along frequently but will change a patient's management significantly, whereas UPP and EMG are not going to change your management of that patient at all. I would argue that while we're limited on what we can do, we should focus on doing tests that could be relevant.
Yeah, I agree.
Okay, thank you.
Thank you.
Probably we have to move to the next speaker. And I just have to apologize because I will have to leave during your talk because I have my plane. But I'm very pleased to welcome Altaf Mongera from Sheffield.
It won't be a reflection of the content.
No,
No,
absolutely
I hope
not, please.
hope not. Okay, thank you very much, Chris and Emmanuel. My name's Altaf Mangera, and I work in the Princess Royal Spinal Injuries Unit and also at the Royal Hallamshire Hospital in Sheffield. And I'll be talking to you about OAB in men. We'll start off with a few definitions, talk about some epidemiology. We'll talk about the assessment of male OAB. Sorry, it's a bit like sucking eggs for some of you. Then it's the management of male OAB, and then the management of OAB stroke BPO, because not all men will present with just OAB itself. And then I'll present some work I've done on genetics of lower urinary tract symptoms in men. And then I've had a look through PubMed and the latest EAU abstracts to tell you what I think is new. So definitions. Everyone knows the definition of OAB, and that was first described by Paul Abrams in the ICS standardization document back in 2002. And it's urgency, with or without urge incontinence, usually with frequency and nocturia. And there's a lot of ifs and ands, with or without, and usually in that. And for the purposes of this talk, I've defined a male as an individual with a Y chromosome, with or without phallus, usually with a prostate and facial hair. And then subsequently, Halen, who's published quite a lot of ICS standardization documents, changed the order around a little bit and added in the absence of urinary tract infection or any obvious pathology. But if you look closely, that standardization document is just for women. So for men, we've got to refer to the above two definitions, and that's what I've used for this talk. Okay, so a little bit on epidemiology. If you look at the EpiLook study, which is an internet-based study from the USA, almost 10,000 men. They selected only men above the age of, patients, men and women above the age of 40, and 27% of men had OAB sometimes, compared to 43% of women. The Noble study had 2,500 men above the age of 18 and had a lower prevalence because the definition of OAB was slightly different in how they went about it. And then Ian Milsom combined data from 5 European Union countries and also the UK. Sorry, Manuel. And there's the largest cohort, 16,000 men above the age of 40. And if you look at the Noble study, I don't have a pointer, but the incidence of OAB in men and women is roughly mirrored throughout the ages, and there's a pretty Venn diagram for people to look at as well. So when it comes to assessment of male OAB, you take a history, obviously, do a bother score if you can be bothered to do so, perform an examination and a digital rectal examination, perform a dipstick, uroflowmetry, post-void residual, exclude the red flags, they're all kind of mentioned in the NICE guidelines, discuss a PSA if it's relevant to your patient. We'd all do a bladder diary to look at their, exclude any polyuria or nocturnal polyuria that they have. I told you it'd be like sucking eggs, Tamsin, but there it goes. Then once you've done all that, you should have enough information to decide whether they've got OAB, so pure OAB, whether they've got more voiding symptoms or only voiding symptoms, and whether they've got obstructive LUTs or whether they've got combined OAB and BPO. So going on to management of pure OAB. So, yeah, you start with all the lifestyle advice, cut down drinking tea, coffee, bladder training, manage the diabetes, manage the heart failure. Okay. Then you go on to antimuscarinic agents. And if we look at just men, so when I looked through the literature, I looked at reviews or studies that only included men and that weren't contaminated by women, who seem to be the majority of, for the purposes of this talk. And there is a systematic review, so that's level 1 evidence by Kaplan, 2011, which has shown that antimuscarinic agents, different antimuscarinic agents, are beneficial significantly in men, so they can be used. Tubaro more recently published a review of pooled analysis from 5 different RCTs, showing that mirabegron in men, if you exclude all the women, is beneficial. And then Abrams showed that you can combine an antimuscarinic and mirabegron in men, and they are significantly beneficial. If you've got to that stage and your patient's still very symptomatic, then I think it's probably time to move on to urodynamics, because all the treatments become more invasive afterwards. After the urodynamics, if it shows that there is diffuse overactivity, then you can consider PTNS. So I looked through the literature, I found 4 RCTs, again contaminated. There were only 57 men that I could obtain from the 4 RCTs that were included in those trials, but there's no sub-analysis. But overall, if you take a combined population of men and women, the RCTs do show that it is effective. The only problem is the longevity of treatment and needing to have repeat treatments afterwards. And then I did a systematic review for European urology, which was updated more recently. And we had 13 level 1 and 2 studies, prospective high-level studies, 1,328 patients. The majority of them are women. At an estimate, because not all the papers define how many men and women, and they don't split the outcomes either, but about 10 to 15% of those studies are on men. But unfortunately, nobody, because they haven't presented the data, has done a sub-analysis just for men. And similar with sacral neuromodulation for overactive bladder, there is no sub-analysis just for us men, guys. Okay, so moving on to more interesting things. Patients don't just present with storage symptoms. Sometimes they have a combination of the two. And it's quite a good diagram. It shows the complex interplay of the bladder and the prostate, the normal aging. There's a lot of basic science research as to whether if you've got an enlarged prostate that's encroaching on your bladder or causing ischemia or leading to your bladder having to work harder and becoming thicker over time, whether that leads to OAB itself. But there's nothing conclusive from any of the science or any of the correlative studies out there that one leads to the other, or whether they're two separate entities altogether. But there's probably a lot of different factors at interplay in that. So you've got a patient, then you've got to manage them. They've got mixed OAB and BPO symptoms, so what does the evidence say you can use? So obviously lifestyle, we've talked about that already. So Abrams has shown that antimuscarinic agents in men with OAB and voiding symptoms does work and has significant efficacy, and there's a low risk of acute urinary retention. Niti has shown that mirabegron can be used in these men without much problem. And then there's some data on combination therapy. So alpha blockers and antimuscarinic agents, whichever company makes them, have done their own kind of trials. So you've got Versomni and Fasteridine with another one, etc., etc. And all the studies that have been done show that they are effective compared to placebo. Mirabegron and an alpha blocker, that's another one that's been trialled, RCT, showing that if you do add in mirabegron to an alpha blocker, your functional bladder capacity increases, your Qmax improves, diffuse overactivity can resolve in about 25%, or it can at least delay the appearance of diffuse overactivity when they've done urodynamics. I'm sure a lot of drug companies would like you to prescribe all three. We mustn't forget that there's COMBAT and MTOPS data for the use of 5-alpha reductase inhibitors in men with prostates greater than 30 grams. And also, if men have concomitant erectile dysfunction, we could also prescribe a PDE5 inhibitor. So there's 5 different medications that you can use in a man with OAB stroke BPO, whether he has erectile dysfunction or not. So does anybody know how to calculate how many combinations of treatments you can have? I think it's 5 factorial, which is 120 different combinations. You can have monotherapy, dual therapy, triple therapy, quadruple, pentuple therapy. You can have 1 with 3, 1 with 4, 1 with 5, 1 with 2, 1 plus 2 plus 3, 1 plus 2 plus 4, etc., etc., etc. So when a patient comes to see you in clinic with this problem, you've got 120 different things to consider, and that's a quandary. Okay, and then if they've got to that stage and they're still not better, then you can perform some urodynamic studies on them. If you do urodynamic studies in men with combined symptoms, 1/3 of them will show bladder outlet obstruction. Diffuse overactivity is seen in just over half of these patients. If you do prostatectomy, TURP, open prostatectomy, then 1/3 will have persisting diffuse overactivity afterwards. That was Paul Abrams. And then the Bristol study, they followed them up for 10 years after a prostatectomy, and the incidence of diffuse overactivity does increase over the 10 years according to that study. So whether to do a TURP or not, the only predictors of success that I could find from the literature were if they had predominant voiding symptoms, it seems a bit obvious really, and whether they had a single terminal diffuse overactive contraction compared to having early phasic diffuse overactivity. And so they're the men that you would want to do your TURP on or avoid on. Okay, we've also got the upstream study that Marcus Drake is leading on, which is looking at this cohort of men, and that will hopefully reveal a bit more information for us. So some work I did on genetics, which we published in European Urology. We did a meta-analysis of single nucleotide polymorphisms in males with LUTs. There were 70 reported SNPs in the literature. There were 35 meta-analyses that we performed, and 5 of them reached statistical significance. And they were the ACE gene, which is protective against having male or developing male LUTs, the ELAC2 gene, which put you at risk, the GSTM1 gene that put you at risk, TRT put you at risk, and also the vitamin D receptor gene put you at risk of developing male lower urinary tract symptoms. Okay, so then I trawled through PubMed, and I was quite stringent using my criteria for male OAB to see what had been published within the last year or so. The things that caught my interest, I've mentioned this earlier, so Tubaro has combined male patients from 5 different studies and shown that mirabegron is beneficial up to 1 year, regardless of whether a man has BPE or is taking a concomitant alpha blocker. I mentioned earlier that Botox, we don't have a lot of data for men specifically. So this study, 88 men over 6 years, 25% were still continuing with Botox treatment at 6 years. And the long-term risk of ISC, which is not very well defined in the literature, is actually 24%. So it's a good finding to keep in the back of your head. Another interesting one, and I've not really thought about this before when I see a patient in clinic, as whether they're taking antidepressants or not. So taking venlafaxine increases your risk of developing OAB or OAB symptoms compared to sertraline. So that's something we can all take back and look at when we see our patients in clinic. So EAU science, and there's a lot of studies on rats and rabbits, a lot of different inhibitors that can reduce the micturition reflex or reduce diffuse overactivity in various rat and rabbit models. But we've just got to remember, when I looked at all of these abstracts, all the rats were female rats. Okay, so clinically, what was new at the EAU? So I thought this study was quite something I hadn't come across before. So 52-week follow-up of tamsulosin and dutasteride versus tamsulosin, dutasteride, and imidafenacin in a combined OAB-BPO group. And 125 patients were followed up to 1 year. And in the triple therapy group, surprise, surprise, there was significant improvement in the symptom scores and the quality of life compared to a dual treatment group. Another thing that I hadn't really thought about when I run my clinic is men with type 2 diabetes and late onset hypogonadism. So we're increasingly seeing more and more of these. And they find testosterone less than 12.1 as hypogonadism. And giving them testosterone replacement actually improved their lower urinary tract symptoms. So that's a sixth medication you can add to your 5 earlier if your man has type 2 diabetes and late onset hypogonadism. Okay, and then the final study that caught my interest was, again, a combination of silodosin stroke fasiteridine versus silodosin and mirabegron. So it's kind of silodosin versus mirabegron in a combination arm. And the fasiteridine actually improved the OAB symptom score more significantly compared to mirabegron. However, there was a 30 ml increase in the residual volume, which is probably clinically insignificant. And there was a higher resolution of diffuse overactivity, 64% versus 33% for mirabegron. Thank you very much.
So thank you very much for that very comprehensive overview. I have one question, which would be, are there any data out there looking at the combination, as that seems to be a very trendy thing to do, of TURP plus Botox?
I've not come across... So I've not come across any data. And the question would be, which do you do first? And I think if there was definite evidence of obstruction on their urodynamics, then you would de-obstruct them and then do the TURP, because the incidence of retention would be expected to be, but it's not been shown to be higher.
I was more thinking along the lines of simultaneous treatment. So if you've got patients who don't fulfill your criteria as those whose diffuse overactivity may disappear, so either those who don't have terminal DO or don't have a single phasic contraction, they have wild overactivity and significant obstruction on voiding. Is there a place for TURP and Botox combined?
I wouldn't do both together, because you don't know what's worked. And if they go into retention afterwards, catheterizing through a TURP, which is fresh, is going to be a bit difficult. You can always assess them after the TURP, because that's the more significant intervention. I'd do that first, personally, but there's no evidence.
We've got some questions from the floor.
Have you ever asked about the bowel symptoms in these cases? Bowel, any problem in their bowel? GIT symptoms, lower GIT symptom, for example, constipations, chronic constipations, or irritable bowel?
Irritable bowel in relation to a man with OAB?
Yes.
Yes, so I said you should take a history, and that should be included in the history.
Any combination?
All right, are there any correlative studies showing that if you've got male OAB, you're at higher risk of having bowel abnormalities? Is that what you're saying? No, there's no correlative studies that have looked at, whether you've got this and that condition.
I have 50 cases that most of them that have got overactive.
So
they have got irritable bowel.
So you've got a symptom score or something that's validated for male OAB, so OAB-SS or whatever, and you've got the same for the bowels validated question score. Is that what you're saying?
Yes.
Yeah. So you need to publish that then, because nobody's looked at that.
We've got Lawrence Stewart at the back, I think. Is it Lawrence?
Yeah, I'm rather concerned with this move in the direction of multiply drug therapy for these people, particularly folk who are at an age where they're on multiple other drugs as well. I think we could spend our whole budgets on giving people drugs, which is clearly not a good thing to do. And you didn't mention the Herbison meta-analysis from, was it 2000, where the improvement was 0.4 episodes of urgency or something per day, which is hardly startling. So can you have some idea of where we might go other than multiple drug therapy?
I mean, I think that's one of the quandaries. So you've got a lot of different medical options, medical therapeutic options for your patients. And it's about sitting down with them and working out what it is exactly that's troubling them. Besides pharmacotherapeutic interventions, the next line is surgical. And the whole idea of medicines is that they're less invasive than surgery, and that's why they've been developed. I do agree that you can't put patients on 5 different therapies just for one condition. And it was a bit tongue-in-cheek the way I kind of explained it. I don't expect everyone to go back home and do that. But you've just got to decide what it is that's important for your patient and give them the side effect profile and the risks of each medication that we have, and give them, what suits them specifically.
But I do think we're too quick to put people on multiple drugs, whereas we as surgeons don't know that much about them. And I think the long-term side effects of being on something a long-term is significant.
Of course, and we should, like I mentioned, lifestyle intervention should always be the first port of call, and I did put that out there.
Okay, we'll leave it there, Tamsin. Go on. We won't leave it there.
I just presented the study as it was shown in the EAU, but you can ask them to lose weight, but it's harder said than done, isn't it?
Thank you very much. So for our final talk, we've got Siobhan Wolsey from Belfast, who's going to talk about urinary incontinence in the elderly. Thanks, Tamsin.
Yeah. Well, when I started off to do this talk, urinary incontinence in the elderly, I just thought it kind of mirrors urinary incontinence of all age groups. So it's a massive talk, really, looking at urinary incontinence and then the added caveats of the elderly. So I thought it'd focus on a few aspects. And the first thing to look at is, what is elderly? If you sit and start from a language point of view, the elder is still a veneered term, still used in church circles, highly respected. And certainly from a population perspective, that's not what we would think of when we're talking about elderly. Is it simply age? But if we look at our retirement, and if we look at our own retirement and when we're all entitled to our state pension, etc., it's getting older and older and older. So the age at which people retire is probably not helping us to define what elderly is. If we look at it from a lower urinary tract perspective, beyond the middle age in females, postmenopausal status, should that be more relevant? Or the role of the prostate, which we've already heard about. So if you come into your mind to think, what is elderly? What is a vision of an elderly female? I'm quite sure it wouldn't be these two glamorous ladies from Hollywood. Sprightly 79-year-old here on the left, and Honor Blackman here is 91. So it's not something that would spring to mind if you're thinking about the management of the elderly patient. Similarly in men, these would both be elderly probably. Michael Douglas here on the left is 72, but his father is now over 100. So is it reasonable to think that you would treat the elderly all within the same bag? Because this is two generations with 30 years apart. So their treatment options would probably be completely different. So if age doesn't really help us in defining what elderly, should we look at more physical health? If these two patients are the same age, we've got the moribund cachectic nursing home resident here on the left versus a marathon running male here on the right. And certainly our treatment options, despite being the same age, would be completely different. What does people think in general? This was a survey of nearly 55,000 people aged 15 and over, carried out across Europe. And you can see that the blue line is the perceived as end of youth, and the pale green is the start of old age. So you can see there's widespread variation in what we think old age starts and even what young ends. Norway, for example, the end of your youth at 34, whereas Greece, you have nearly 2 more decades, you're 52. What we do know, however, is that the older population is increasing in numbers. And if you look at the figures here, up to the yellow line, they more or less are staying the same for all these parameters, 0 to 14, 15 to 29, etc. But if you look at the top two, the pink and the purple, in 2014, this is representing about 15% of the population, so greater than 60 at present, representing 15% of the population. But if we project that out to 2039, it's about 25% of the population, with 10% of those being in the greater than 75 age group. And similarly, the over 85-year-olds are getting increasing numbers as well, and expected from the Office for National Statistics probably in the region of about 5% of people in 2035 will be over 85. This has huge implications from healthcare economics and management of chronic conditions, of which urinary incontinence is one of those. And this is it's a big document, a government document of future of an ageing population, and I just took a few pointers. In mid-2014, the average age in the UK for the first time was greater than 40 years, with 1 in 7 people being greater than 75 years. The working population from the age of 50 to the state pension age will increase from about a quarter in 2012, expected to go up to about a third. What relevance has that to management of chronic conditions such as urinary incontinence? If you were retiring a bit earlier and had a little bit of incontinence that maybe wasn't too problematic with the lifestyle that you were leading, but if you're being encouraged to stay in employment and gainful employment, your expectations of management of your urinary incontinence may be different. There's a huge shift in healthcare provision from the acute setting to the chronic setting, with a big difference in structure of family and unpaid care. So caring for a patient with incontinence is shifting, being relied more on state, for example, than would have been relied on in family. So these are all aspects that are important. If we looked at what happens to the lower urinary tract with age, we don't actually know what normal is. And no two patients age at the same rate, so no two people's bladder ages at the same rate either. But we do know that there are age-related changes in the lower urinary tract. We've got impaired detrusor contractility, decreased bladder capacity, decreased compliance, decreased first sensation to void, and that's male and female factors. And then you've got the added caveats of what happens in the male with the prostate and what happens in the female with the lack of estrogen, and the pelvic floor changes, decreased maximal urethral closure pressure. You also have increased post-void residual. As in all age groups, we're not exactly sure what a significant post-void residual is. Various figures have been used over the years, but maybe a lower volume may be more significant in someone that has these other age-related changes in their lower urinary tract. So bladder emptying efficiency, for example, if you've got early sensation to void at 100 mils, but you've got a post-void of 100 mils, that may be much more clinically significant to that patient versus one who voids 500 mils with the same volume of 100. So it may be very difficult to assess. As urologists, we will focus on the lower urinary tract as our symptoms and history examination, etc. But in the elderly population, we probably should focus on what's happening outside the lower urinary tract before we think about the lower urinary tract in itself. The brain size shrinks from the age of 40, about 5% per decade. And again, not the same in each person. Yeah, it's quite worrying when you look at your own age. But that has an effect on cognition, dementia, mental health, sleep disorders. And if you think of all of those in themselves will affect your lower urinary tract. If I just took one aspect of that, of dementia, 2/3 of patients currently with dementia live in their own home. They live in the home environment. If you have incontinence, and that is either urinary or fecal incontinence, it significantly increases your risk of being institutionalized. And if you think back to the healthcare economics, that's going to be a huge problem as the years go by for healthcare provision and basic management of these patients who are trying to be left in their own home environment. The endocrine system, exceedingly complex, even taking into consideration nocturnal polyuria. If you take that out of the equation, more urine is excreted at night. ADH, the major hormone responsible for regulation of urine production, you get blunting of the nocturnal phase of that, resulting in increased urine production. But all these other mechanisms can also take place. ANP is probably more important than what's been given credit, related to cardiac and chest dysfunction, etc. Constipation has a huge impact on the lower urinary tract in every aspect of it, including infections, etc. Mobility in the elderly, and I've put here motivation first of all, and I had a patient at my clinic who was the mother of one of our nurses who'd asked to see who'd suddenly developed incontinence. She'd sustained a fractured neck of femur. She made a very good recovery from that. She went back home. A few weeks later, she had a fall. She sustained a fractured pelvis. She's petrified to get out of bed in the middle of the night, even to a commode that's beside her bed. Prior to her sustaining her most recent fracture, she'd 2 to 3 times nocturia. it's easier to leave the pad. It's easier to use the pad than it is to get out of bed and risk a fall, because that's what's going to stop her being able to live in her own home. If you've got some of those age-related changes of your lower urinary tract and you know that you're never going to make it to the bathroom, you may rely on containment products. You may not. What's the point of making the effort? So you need to assess, is there motivation that maybe the lower urinary tract maybe isn't a problem. Dexterity and falls are important, and we would all accept that falls are an increased risk of urinary incontinence. But what's the evidence? This was a systematic review published in 2013, and the general outcome of this paper was there was so little research on the impact of continence management of falls. But in more recent years, there's more work being done. And this was an interesting paper published, J. Urol 2016, of over 1,000 men who had no neurological disease, poor mobility, or dementia. And what this study did show was that LUTS and voiding symptoms were associated with falls, of which OAB symptoms constitute the higher risk, which makes sense with urgency and urge incontinence being primary symptoms of that. Drugs and polypharmacy, be aware of the drugs that actually may be causing the incontinence. But what has become the new buzz term in urology terms in the last few years has been the anticholinergic burden. And it was a fairly new phenomenon, but it's not really. It's been known in geriatric papers, etc., for many, many years. But it was, I think, became more relevant to us because there was a new drug in town for the management of overactive bladder, which didn't have any anticholinergic side effects. And simply, this is the cumulative effect of taking medications with anticholinergic properties. But there are numerous factors involved. Similar to patients don't age at the same rate, their lower urinary tract, they may not respond to the anticholinergics to the same rate either, and they may be more sensitive to them. Pharmacokinetic changes may be different. Changes in the elderly, such as the blood-brain barrier, and there's been various selling points of various drugs for overactive bladder over the years with an effect on that. What's the relevance? Impact on cognition, physical function, falls, mortality. Overall, the increased anticholinergics has more negative outcomes in the elderly. How can it be calculated? Very complicated when you look at all the literature that's available. Clinically, do you have any side effects? But there are numerous rating scales, all of which are interchanged and used at various degrees in different studies. And you can measure individual drug-related acetylcholine activity, and that can be measured high, medium, and low, or sometimes they're given a numerical value. But I was quite surprised that there was masses and masses of this in the literature and what's available. But I was surprised at the amount of drugs that actually do have anticholinergic activity. Warfarin, for example, ranitidine. And when you look at polypharmacy of the elderly, this is probably important. I haven't gone in to look at a lot of the studies, but we all know that antimuscarinics are safe. There are numerous studies in the cognitively intact patient. But a lot of these patients, as they get older, may not be cognitively intact and may have dementia. So where are we with the use of the drugs in these patients? And this is an example of a paper coordinated through the National Alzheimer's Coordinating Centre. Big numbers of nearly 24,000 patients, and they underwent an annual assessment. 5% took an antimuscarinic, but the participants with impaired cognitions were more likely to be taking an antimuscarinic, increasing further in those with dementia. And if you looked at the patients with dementia, 16% of those were also taking other medications with anticholinergic properties. So it is probably prudent to assess cognition prior to prescribing anticholinergic, but that is no mean feat. That is a very complicated process, of which is probably outside the remit of our 15 to 20-minute appointment that we have at our clinics. So moving on then, incontinence, we all know that's involuntary loss of urine, but that's a social or hygienic problem, because sometimes one pad per day may be an easier option than having any of the treatment options available. But it is not a normal aging symptom. It shouldn't be accepted as normal because of my age. And a lot of patients do come with that adage, oh, you can't do anything because of my age. But we do know that it increases incidence with age, and as with all age groups, there's a significant underreporting. So it is a major problem, but the natural history is unknown, and it is a question that patients would quite often ask. I'm not too bothered with my urinary incontinence at this stage, but am I going to get worse? And quite often we can't answer that question. The prevalence and incidence of urinary incontinence is more common than hypertension, depression, or diabetes, and at present between 3 and 6 million people in the UK probably have some degree of urinary incontinence. those that are 15 to 30% are in the community, but the more likelihood of you having living in a care facility, you have a much more significant chance of having urinary incontinence, and women are more common than men. We're all aware of various mnemonics that have been described, such as diapers, to rule out the easily reversible or treatable causes, but it is very multifactorial. And although I've put the lower urinary tract, you need to rule out the neurological, Parkinson's, gynecological prolapse, environmental factors are iatrogenic, of which drugs is a big contributor. And causes do mimic causes in all age groups, but detrusor overactivity is most common in the elderly. But you've also got detrusor underactivity, if you think back to those age-related changes, and the situation of DHIC, which can be very difficult to manage, stress urinary incontinence, but functional, impaired cognition and impaired mobility need to be assessed, first of all, before you look at all these other causes. Assessment of an elderly patient with urinary incontinence needs to be very much tailored to the individual. And the first question is, what are you treating? If you have a woman, for example, who presents with stress urinary incontinence and you do an anti-stress procedure after they've been through pelvic floor muscle training, etc., and they're dry, but their primary complaint was that of nocturia and their impaired mobility at night, you maybe haven't cured the symptom that was bothering you. And we have had a lifetime of research really looking at objective IPSS, pad weights, etc., etc. We've moved a bit along that to the PROMs, patient-reported outcomes, and we'll probably go a step further going, what do you want? What do you want to gain from any treatment that you are providing? What are the expectations? And not only our patient expectations, but their family carer expectations before we think of physician expectations. But we must be realistic in our goals. Functional urology involves a lot of assessments and tests. It's very important to rule out your diabetes, UTI, etc. But you have to remember that a bladder diary, for example, in a cognitively impaired patient may be a significant intervention in itself. That may not be feasible for that patient, so it can be difficult to plan treatment. Treatment options then, and this is where from here it does mirror all ages of urinary incontinence. Behavioural techniques are pelvic floor muscle training, medication, modulation, surgery. And I've left a deliberate gap for containment products or pads, because it's not our aim to say your elderly have pads, that's your lot. But this was an interesting paper, Systematic Review of Cure Rates, Can Continence Be Cured? And it showed that at most types of incontinence, no matter the treatment option, there's usually some reliance on containment products, be that antimuscarinics, or even stress incontinence procedures, which are pretty high results, 85%, for example. Behavioural techniques is most appropriate for cognitively intact, but it does work for patients who can do it. But possibly more beneficial to patients who are elderly, nursing home, is timed or prompted voiding, but again, very time-consuming for the family or the carers. So in summary, urinary incontinence in the elderly is very complex. The assessment and the treatment must be tailored to the individual, and perhaps a multidisciplinary approach, especially with their geriatric colleagues, perhaps an assessment of anticholinergic burden. But as well as the lower urinary tract, motivation, cognition, mobility and dexterity all play a very important role. Thank you.
Thank you very much, Siobhan. We'll open this to any questions from the floor. Tamsin.
That was an excellent talk. I feel very depressed about getting older. Thanks. That was an excellent talk. Thank you. I was saying I feel a bit depressed about getting older, but Mrs. Venn's always older than me, so I'm just going to watch her. Are there any sort of specific tests or treatments you can offer to the elderly person who's getting slightly cognitively impaired? In America, there was one of the physicians did a special test where they had to walk to the toilet and back and sort of show what they normally do to try and help with OT and sort of behavioural things in that way. Because when we think of behavioural things, we think about pelvic floor exercises, but I think in the elderly it's more of a sort of OT, isn't it?
Well, it's timed or prompted voiding is what's described, but prompted voiding needs someone there to prompt them with their cognitively impaired, or if they have a degree of cognitive impairment. So these are a lot of these patients have people coming in for carers. So at the very early stages, they may be prompted by clocks, and it's you tell people, you know, the previous talk of urinary retention, for example. You would say, you go by the clock, you need to time, or you have your coffee, you void, you do that twice or whatever. So yes, behavioural therapies are completely different probably in what we think in this age group.
So there's a big drive away from anticholinergics with the whole anticholinergic burden and the literature that surrounds that. Is there any analyses of the use of mirabegron in an elderly population specifically linked to cardiovascular side effects?
I didn't see anything of recent times, but I think that's only starting to come in. It's only starting to help. I think NICE guidance is still being followed with your 2 anticholinergics followed by mirabegron. But certainly I have seen it, the hypertension and if patients are on AF and warfarin, that's probably a much more significant side effect than one that's impaired cognition with an antimuscarinic. So it's...
There was a suggestion at one stage that the anticholinergics actually caused cognitive impairment long term.
Yeah.
Does anybody actually suggest to their patients, does anyone warn their patients of that side effect? I'm personally not convinced it's true, but I just wonder what people's practice is with respect to that when they start people on anticholinergics.
I have mentioned that to patients, but all of the studies have shown in cognitively intact patients, antimuscarinics are safe. But we don't know if the cognitive impairment that those patients, would they have developed cognitive impairment at the same time? Because cognitive impairment, you're 5% down on your brain function over the age of 40, 50, 60. So it's difficult. Any study would be difficult without exceedingly massive numbers and complex.
I think there's a Daily Mail article, isn't there, for oxybutynin leading to dementia. So I was getting a lot of letters from patients, spinal injury patients that have been on oxybutynin for donkey's years, saying they don't want to take it because it can cause dementia. I think it's just a correlative study. There's no causality shown in that study at all. The other thing, there is evidence for trospium not crossing the blood-brain barrier in patients. So if someone's at risk and you're not worried about cost, then you can put them on trospium, or even Adrian Wagg's published on solifenacin and vesiteridine in an elderly population over the age of 65 causes less cognitive dysfunction than oxybutynin.
I think that comes from, is it the Gray paper in the New England Journal of Medicine that I think was published about 3 or 4 years ago, and the papers have only recently, for some reason, picked that up again. What you need and what you probably will never get is a longitudinal study over decades looking at, you know, a cohort who have a high anticholinergic load and those who don't, and if there's any difference. But that would be a very expensive study to run. We'll probably never get it.
But our care of the elderly physicians think that your incontinence heralds as a forewarner of your cognitive impairment, and that you find the association with those who are cognitively impaired being on anticholinergics because it's your preliminary symptom, just like your ED predicts your heart disease.
Richard?
I think we have to be a little bit cautious about dismissing the New England Journal paper, because they did control for that. And none of us really want to believe that the anticholinergics are going to cause a problem. But the paper certainly suggested there's a strong reason to believe that it might do, or it does. So I don't think we can say to our patients, these are safe and they're not going to cause cognitive impairment. What evidence there is suggests that it may well do. And this isn't, of course, an issue just for elderly people. This is people who are in middle age, because it's a cumulative risk over many years. So I just think we should just be slightly cautious about saying this is all rubbish and it doesn't happen. And I don't think you can say that trospium doesn't cross the blood-brain barrier and doesn't cause a problem either. I think that's been debunked.
So back to my question then, Richard. Do you warn younger patients when you're starting on them about the risk?
It's very difficult. I think a lot of them are already aware of it, and I don't really know what I should be doing with that.
No,
I think
that's
it's
why
a very important question, but I don't think we can say, oh, you don't have to tell anybody, because it doesn't exist.
But on the trospium point, it was the selling point of trospium in a reduced crossing of the blood-brain barrier. These are all the selling points of one drug's benefit over another, so you tailor it. But yes, there's probably not a lot. But we would all accept that oxybutynin, although well tolerated in the spinal injury group of patients, for whatever reason that is, has a significantly higher side effect profile than the other selective antimuscarinics. So, but if you follow NICE by that's your first line treatment.
I mean, another thing to think about is that mirabegron doesn't cause dementia, but it does cause other problems in the elderly, doesn't it? And
Exactly
it's 6 of one and half a dozen of the other. Drugs
I
are bad
think
for you.
the antimuscarinic burden is just something that's only sort of been opened up as an issue. If you go and look at what the scores say, which is overlooked whenever the rep's telling you about mirabegron, they overlook what the scores, because it's not a score. A 1 is in vitro laboratory suggestion of an antimuscarinic effect that's not been seen in people. 2 is expert opinion or thought to cause acute delirium, not long-term cognition. And a 3, known to cause by expert opinion cognitive impairment or have an antimuscarinic effect. And so all antimuscarinics are grouped as a 3 based on that descriptor, regardless of the clinical trials about their effect on cognition acutely. So 2 1s doesn't make a 2. You could be on 100 1s, it may not have any real-term effect. So I think it's something we need to be aware of, but the scores and the summation of scores and the interpretation of that is just too uncontrolled, too variable, and I don't think there's a consistency of effect that we can take that as read yet. You need to be really critical about those papers and what actually anticholinergic burden somebody has is. And again, the causality and correlation, I think. So I don't tell my patients that because I'm not fully sold on there's enough science to tell me that that's something I should be telling my patients.
Any other comments before we close? One more. Just take this for the mic.
Thank you. It's just a comment on elderly patients on the wards somehow get a catheter, and that's never revisited again, and they just end up with a catheter forever. I think it's just important to drive home the message is to reassess whether they actually need the catheter. They've had it for one episode, and then we see them back in clinic. I see patients quite often, months later, and they don't actually need the catheter in, and it's to try to get rid of the catheter as quickly as we can for patients. It's just an additional comment on.
I think we'd all agree with that. Could I just finish then by thanking the 3 speakers for making it such an excellent session, and thank the audience for your participation. Thank you.